Hello, everybody, and thank you for asking me to present. I'm pleased to be part of the Asian Pacific Athletic Training Society virtual forum, so I hope you enjoy this presentation. My goal for today is to give you some practical applications about the overhead squat assessment and how to choose and how to use. I've used several, but I find that probably one is very easy to learn and to utilize, and you can get a lot out of it. So hopefully today I'll be giving you some really clear, pragmatic ways to move forward. Hello. Welcome. I have no conflicts of interest to disclose. The objectives for today are to introduce you to a number of different assessment protocols. I'll go over 2 or 3 that I've used in the past and kind of give you the pros and cons of those. I will help you understand how to complete an overhead squat assessment. By the end of this, you'll be able to be very attuned to being able to do that. I could talk to you a little bit about overactive and underactive muscle function and how it affects movement. And you'll be able to create protocols for patients who exhibit movement imbalances, and that's the ultimate goal. The one overhead squat assessment that I'm going to talk the most about is the NASM overhead squat assessment. And the assessment part of this is important. When you see assessment, you know that it's going to be part of a larger protocol. It's going to be an actual assessment of the movement. Gary Gray also has a couple of different tools out there, the functional movement screening. And that's the difference. The screening is really screening movement and not really assessing movement. And there's a difference. Screening is more for performance and looking at it from a performance point of view, and assessment is more from a healthcare provider's assessment. So you'll also see that Gray Cook also has the selective functional movement assessment. This is a really outstanding assessment. It is very complicated at first, but as you use it more and more, there are some things that you can get from this more advanced assessment that you can't necessarily get from the overhead squat assessment, but I like to build these. So when I'm teaching these skills, I'll typically go into the overhead squat assessment by NASM, follow up with the selective functional movement assessment by Cook, and then another really advanced way to look at movement is Gary Gray, who does the chain reaction. It's also known as the chain reaction transformation, which he just switched over recently to the chain reaction 3D. This is a really high-end type of protocol that you really have to know your anatomy inside and out. You do for all of them, but with the Gary Gray transformation stuff, you've got to know how muscles act and function. So not just the concentric, but the eccentric and the functional eccentric, and it's a very high end, something that I would highly encourage you to work towards, because I think looking at how someone moves is the cornerstone of everything that we want to do with a patient. We want to see how they move. We want to see how their muscle function is. We want to see what the range of motion is. We want to see what the force coupling is. And we want to see how we can adjust and fix someone's movement patterns if there's a dysfunction that's causing them pain or a dysfunction that is causing them not to have optimal performance. Those would be the 2 goals. There are normal dysfunctions in individuals' movement patterns that are part of the sport, which I wouldn't try to fix or wouldn't try to do any types of adjustment or correction. And one of the examples of that is really a baseball thrower, a pitcher. They have a lot of external rotation, minimal internal rotation. And when you look at that bilaterally, you would say, wow, this individual really has a difference in range of motion. But typically with those types of things, you're looking at arc of motion and you're looking at performance and what sport they're doing. So that's important to look at as well. So we will spend most of our time on the NASM overhead squat assessment, along with a couple other things that I've added in at the end, which is a step-off procedure, a standing long jump, which kind of a throwback from elementary school, right? But it actually gives us a lot of really good information, and the vertical jump assessment. So we'll get into those as well. So like I've said before, the NASM overhead squat assessment is probably the quickest and the easiest test to perform. And I like to do these at the start of the season. Typically, the bad thing about sports sometimes is especially fall sports, is you get athletes in here, patients in here, and you really don't have time to do the correction. So the best time to actually do the overhead squat assessment is typically around 6 months prior to the start of the sports season, if at all possible. I know that's extremely difficult, but once the season starts, you all know how hard it is to get compliance for a program or be able to focus on a program when performance and outcomes of their sport becomes the primary objective. The information that's obtained from the overhead squat assessment can really be tailored to do a prehab program, a prehabilitation program, specifically for the needs of each individual athlete. This isn't something that you're going to be able to do in a group and put group exercise programs together. This is really a personalized approach depending on what you find with the screening. A word about prevention. We are prevention specialists, but I don't think we spend enough time on prevention. It's something that I really think the athletic training profession has a hallmark in, but we haven't really been able to utilize it to the best of our abilities because we're doing a lot of things that are related to assessment and emergency care when we really should do prevention and prehab. It would serve us a lot better, but time is a factor, and we know that that getting them back into play is extremely important. When you look at the overhead squat assessment, there are two primary movements. You have the overhead squat and then the single leg squat. The overhead squat, you're going to be getting a lot of information about how they are in the bilateral stance position. With a single leg squat, you're going to be getting individualized information about the right and left leg respectively. You're also going to be getting information about the lumbopelvic hip complex and the core. So both of these in conjunction are super important. Also, we don't talk a lot about this in this presentation, but once you do find those movement imbalances, you need to follow up with the skills and knowledge that you have as an athletic trainer and really look at taking out a goniometer and looking at some measurements, looking at manual muscle testing, and making sure that you're assessing this not just from the squat assessment, but really digging into what pathologies might be causing these imbalances and get some quantitative data that you can look at and measure to make sure that we have outcome assessments and make sure that we're looking at quality improvement. Those are super important, and making sure that we have that data is really important. So make sure you do that as well. Like I indicated earlier, we're also going to do some additional tests. These are some things that I have picked up, not part of the overhead squat assessment, but things that I've utilized to look at individual movement patterns, and they're a little bit more dynamic. So why the other one is called dynamic is it's a little bit more static, but the single leg step off tells me quite a bit about stability of the lower extremity. And then I like to do two functional movements, and that is the vertical jump and the long jump. It tells me a lot of information with the preparatory movement and also with the deceleration movements. Okay, so starting from the beginning, what is the rationale for the overhead squat assessment? Well, really what it does is it's going to be able to give us the total body structural alignment. So you're going to be looking at, what is happening at the ankle joint, what's happening at the knee joint, what's happening at the hip and or lumbopelvic hip complex. How is the core being stabilized through this motion? How are the arms working in conjunction with the torso? You're also going to be looking at dynamic flexibility. So what is causing what's causing what? Do we have enough ankle dorsiflexion? Do we have enough knee flexion? What's happening at the lumbar-pelvic hip complex? So we're looking at that dynamic flexibility, not just the static. And we're looking at the neuromuscular control. And in this position, from the overhead squat, it is a bilateral starting position that we will start in. So we're going to be looking at the squat that requires optimal motion at the ankles, knees, and hips. But the arms will be elevated at the time that you're doing this. And I have some videos that are coming up to show you this movement. The arms are up and overhead, and they are going to be near the ears, so that you're going to be able to see the musculature surrounding the shoulder complex. You're going to be looking at the demands placed upon the core and stabilizing these muscles. And typically, what I will see with some of my overhead shoulder athletes, they can't even get into the start position, and I'll show you that in a bit. So what we're looking for with the overhead squat assessment is for them to be able to perform the overhead squat assessment correctly without compensation in structural alignment. And in order to do that, one must be able to demonstrate the optimal and bilateral symmetry in the dynamic range of motion of each joint. So this is considered that length-tension relationship. If something is not working right, if the length-tension relationship is off, you will see an asymmetrical movement as opposed to a symmetrical movement. And we're also looking at optimal force coupling relationship, and this is the ability of the body to properly recruit muscles according to the movement pattern needed. So are the muscles turning on and off? Do you have that reciprocal and autogenic inhibition that is working? Do you have the length tension relationship that is working in order to see this good overhead squat maneuver? So once the compensations are found, what we will be able to do as athletic trainers is we'll be able to look at what probable overactive muscles are firing. So do we have something that's firing when it shouldn't be firing? And we'll be able to look at probable underactive muscles. So do we have something that isn't firing that should be firing? So when you have something that's overactive, so you've got an overactive muscle tissue that's causing some type of deficit in their movement, what we want to try to do is we want to try to inhibit or lengthen that muscle. So we'll do that by doing flexibility exercises. We might use self-myofascial release, static stretching, neuromuscular stretching. And for those underactive muscles, we want to activate. We want to get those fired up. We want to get those integrated. And that is going to be done by strengthening exercises that will be used to help to get those things firing. So we might do, positional isometrics. We might do some isolated strengthening. We might do some integrated dynamic movement. And the best example I can give here is when you're doing an overhead squat assessment. Let's say an individual, their knees start to go into valgus, so they fall into valgus. So this might mean that you have some overactive muscles of the adductors. So the adductors of the thigh possibly are tight and overactive. So we're going to inhibit and lengthen those. And then the probable underactive muscles might be the deep external rotators and the gluteal area in order to help get those to pull out and away so that the knees don't fall into valgus. So we want to activate and integrate those. So we will get more into that a little bit later. So in the corrective exercise continuum, we're going to inhibit the muscles that are overactive. We're going to lengthen the muscles that are shortened. We're going to activate the muscles that are not responding, and we're going to integrate them into a dynamic movement pattern in order to make sure the individual can move successfully. So in this video, you'll see an individual who is in the anterior position. So this is where I'm going to be viewing the individual from the anterior position. And optimally, they should not be wearing shoes. So unfortunately, I have this individual who is in shoes. There's some, it depends on if you want them in shoes or not in shoes, but I like them not in shoes so that I can see what's happening at their foot. But some individuals like to have them in the shoe that they're going to be performing skills in, because that the stabilization you get from there is more functional for what they're going to be doing. So that's up to you. And as you get to use this a little bit more, you can choose how and what you're going to do. But for the most part, you're going to set them up exactly the same. So you want the foot and ankle to be in a straight line. You want those parallel. You want their knees directly over their hips. You've got the lumbopelvic hip complex that you're going to be looking at. You want the arms that are straight up in the air. Hers are a little bit bent. We'd like to have those a little bit straighter. And you want the cervical and spine in a nice upright position. So feet shoulder width apart straight, and a nice straight alignment. She has tight latissimus dorsi, and that was not able to allow her to go into the full position of the shoulder, which we actually worked on after this video. She did some myofascial release stretching of the latissimus dorsi, and she was able to actually get her arms up. I wish I had a video of that, but I don't. So we'll show the video.
Okay.
Here she is going into the squat. She should be doing 5 consecutive squats. I had to remind her. But we're looking at the feet. We're looking at the knees. That's pretty much all we're looking at from the anterior view. So again, we're looking at, what are we looking at here? Well, we're looking at the feet. Do the feet turn out? Do the feet fall into pronation? Do they go into supination? We're looking at the knees. Do the knees go into valgus? Do the knees go into varus? And from the anterior view, which we're in right now, those are the 2 real things that we're looking at here. We're not going to get carried away and try to do our whole assessment from one view. We're going to do assessment from 3 different views. So let's just look at the feet and let's just look at the knees. Let's look at that video one more time. Let's look at the feet. They look pretty good. The knees look pretty good too. The knees are going right over that second ray, that second toe. You're seeing something funky there with our movement, but we'll figure that out probably at a different view. So the other 2 views that we're going to be looking at, I already told you how to set up and what we're looking at from the anterior view. Again, we're looking at the ankles and the knees. From the lateral view, we're going to be looking at the lumbopelvic hip complex and the shoulder. And from the posterior view, we have an opportunity to look at the feet again, but we're also going to be looking at the lumbopelvic hip complex. So what I like to do is I keep my athlete in just one position, and then I rotate around my athlete so that they just continue to do 5 squats. I move, they do 5 more squats. I move, and they do 5 more squats. It takes very, very little time once you get trained in what you're looking at, and then you can go back and look at other things after. So again, a little bit more with the setup, no shoes, tight fitting clothing, feet straight ahead, shoulder width apart, and arms raised above the head as shown in this picture right here. From the anterior view, again, we're looking at the kinematic checkpoints are going to be the feet and the knees. The feet should be straight ahead. Second metatarsal and each foot should be parallel to one another. This picture right here depicts a little bit of external rotation. We want to fix that. Some of your stronger gluteal individuals will probably have a normal stance of external rotation, go ahead and correct that, have their feet parallel together. You might see them go down into a squat and externally rotate. That would tell us we have some deep external rotators or some overactive external rotators, underactive internal rotators. So that tells us something. So we have to make sure that we put these individuals in the right position to start and then to see how they naturally migrate. We're also going to look at the knees, move inward and outward. Again, feet and knees are our primary kinematic checkpoints from the anterior view. This individual is going to perform 5 squats, and you're going to view them from the anterior view. The squat is to the depth of an average chair height, so it doesn't have to be a real deep squat. Like functional movement assessment, you get into a really deep squat. No need to do that here. This is a video, so we'll go ahead and play it. As you play it, you're going to be looking at her movement. You can see on her right foot, she does roll into a supination just a tiny bit. And if you look at it one more time, play it as many times as you need to look at some of these things. She doesn't fall into valgus, so she looks good at the knee, but she does have a little bit of that rolling out or supination that you see on her right foot. So for each one of these views, there are different things to look at. And on the NASM, when you get NASM certified with overhead squat assessment for a corrective exercise specialist, you can look at, they have these forms for every single one of the views. I find these to be helpful, but they're really global. So when I look at the feet, and in her case of the video that we just looked at, the right foot kind of supinates, and there's no real compensation. She doesn't rotate out, she supinates. So when I look at the probable over and probable under, those are generally what is happening if the foot is turning into external rotation or turning out. With this individual supinating, I've got to think about what's going on with the posterior tibialis. Is that something that's of concern? And when I look at the overactive underactive grids, I don't see the posterior tibialis there. So this is okay. This gives you kind of that baseline if what you're finding is in the checkpoints. But when it's not, that's when you need to become that thinking critical appraiser, athletic trainer that I know you are, and be able to look at this from a medical assessment perspective. But this does help a little bit. I think one of the examples I gave you earlier were that the knees, and if they fall into valgus, you're really looking at the adductor complex being overactive, biceps femoris, especially the short head, the tensor fasciae lata, the lateral gluteus maximus, and the vastus lateralis. Lateral gastrocnemius and the vastus lateralis, they're all probable overactive muscles. And then when you look at those underactive, the medial hamstring muscles, the medial gastrocnemius, and the vastus medialis oblique muscles, those are underactive, I would say, also along with the deep external rotators, which aren't on this grid. So you've got to, be thinking about, okay, what's causing them to go into valgus, and what's causing them not to be able to keep their knee over that second ray, and what do we have to kind of turn off? And those would be those overactive. So we're going to inhibit those, and then we're going to stimulate the ones that are underactive, and making sure that they're firing appropriately, and specifically, that those the gastroc, the hamstring, the medialis, and the deep external rotators, and the gluteus, right? So you gotta be thinking. You just can't use this grid. All right, so now we're moving on to the lateral view. This is a video that's embedded here as well. You've got 2 main checkpoints that you're going to be looking at here, and the first one is the lumbopelvic hip complex, we're really going to be looking at, do we have an excessive forward lean? That's probably one of the major things I see specifically in the female patient. Does the back round, or get like a kyphotic? Do you get a back arching, which would be a lordotic? And what happens to to the upper body? Do the arms fall forward? Those are all things that we're looking at. So if you play your video right now, you'll see she goes down, and when she gets into that downward position, when she's almost all the way to the bottom, I look to see, is that tibia parallel with the torso and arms? And for her, she does pretty good. I mean, she's got a nice parallel presentation when she's in the full squat position. And I'm gonna play it again if you can, and go along with me. So right here you'll see nice parallel for the tibia and the torso, and her arms are staying up pretty good. Her arms are staying by her ears. If when she goes down, her arms go forward and you can see her ears from the lateral view, that means the arms are falling forward. You want them to stay right there at that ear. So good look here at the lateral view and what we're looking for from the kinematic checkpoints. As I said, one of the major things that I see specifically with our female athletes is that excessive forward lean. So in the previous slide, I asked you to look at the tibia and the torso, and when they're in that downward position, or when they're in that full squat position, is there a parallel orientation between the tibia and the torso? And you can see the pictures on the left-hand side. This is showing you that nice parallel presentation. This is something that I would like to see with my clients. You'll see on the right-hand side, this is a little bit overemphasized, but this is someone who presents with an excessive forward lean. And you can also see with the excessive forward lean, she's got her arms are dropping. This could be someone who doesn't have a lot of ankle dorsiflexion. Maybe they don't have good knee flexion. It could be someone who has a weak core, tight latissimus dorsi for those arms to fall down. But you can also imagine if someone is squatting or jumping and landing, that excessive forward lean, especially for the female population, is going to cause you to not have a good force coupling relationship of the hamstrings firing and protecting the tibia from translating anteriorly. So two things that, this has a little bit more stress on the anterior cruciate ligament here. No flexibility of the talocrural joint in the ankle, and really weak through the core. So, even though this is a static test, it's not really a jumping and landing test, still is giving you tons of information if you see something like that. So that would be something I would definitely look at, and sometimes taking a video while they're doing this is extremely helpful if you need to go back and take another look. Here's another example from the lateral view of a composition table. So the one I've been kind of picking on a little bit is that the arms fall forward, probable overactive muscles. So you can see there's a cohort of 3 in there, but the latissimus dorsi, I think, are typically the major problematic factors. So I'd want to foam roll that, do some myofascial release on that. And the probable underactive muscles, I would want to fire these up with some type of specific strengthening of the musculature to keep those arms from falling forward. Also with the lumbopelvic hip complex, that excessive forward lean, which is definitely the one I see the most, typically overactive in the soleus, the gastrocnemius, and the hip flexor complex. Really, they're firing too much, want to inhibit those, foam rolling and stretching. And then the underactive muscles, the ones I really want to fire up, are the anterior tib, gluteus maximus, and the erector spinae. So you can see how this is kind of coming together now, where we can look at, what's really firing up when it shouldn't be, and what it isn't firing when it should be. How do we inhibit the ones that are overfiring, and how do we activate the ones that are underfiring? and try to correct that imbalance and correct that force coupling that we're trying to get a movement pattern corrected, and looking at the length tension relationship and try to get that back to normal movement patterns. With the posterior view, the kinematic checkpoints are going to be the feet and the lumbopelvic hip complex. This is a video as well. So with the feet, you want to see if they flatten or go into pronation. You want to see if their heels rise up. Some of my tight gastroc people here are going to really be, they're going to rise up on me. And they might not even be able to do the squat. If you're familiar with a functional movement assessment, they actually use a lift for a correction. It's not part of the overhead squat assessment, but it's definitely something that I add to it. And then for the lumbopelvic hip complex, you're looking at asymmetrical weight shift. And this is a video, so let's go ahead and play it. Her feet look pretty good here. You can see that she does have an asymmetrical weight shift. So if you look at her right lumbopelvic hip area, she does have a little bit of a drop on that side. It's not a lot, but she definitely has a little bit of a drop. Feet look pretty good. Does have a little bit of external rotation also that's happening in that right foot. So there's something that I would want to assess on the right side, and seeing if she has any history of injury. You know, try to dig a little bit deeper into what's happening on that right side. As was consistent with both the anterior and lateral view, there is a check sheet for the posterior view, and to tell you, what the checkpoint is, what the compensation is, probable over and under active muscles. But again, you've got to use your skills and knowledge to really look at what's happening and do a further assessment. Just don't go off of this grid and say, okay, this is what I'm going to focus on. Make sure that you're thinking through these solution tables and making sure that you're looking at everything from both the assessment and using the medical assessment that you have. For this individual, she did have a slight asymmetric weight shift on the right side. So you're going to be looking at the probable over and underactive musculature and try to look at that. For her, she has some tight musculature in her right hip flexor, which was causing some of that imbalance. So again, utilizing this as a possible solution table, but making sure that you're thinking through this and doing a further assessment with the patient so that you can also isolate. So like I said in the previous slide, there is a modification, or I do a modification for the overhead squat assessment. And if someone is having some type of compensation, I will take a piece of 2x4 and put it underneath their heels, and I look at, does it improve the compensation? So let's say someone's falling into valgus, someone is externally rotating when they're doing the squat, then I elevate their heels with the 2x4, and does the compensation improve? If the compensation does improve, well, you probably have a potential lower leg type of issue that's happening. But if there's no difference with and without the board, you potentially have a lumbopelvic hip complex. So, for example, they have a movement compensation. You put them elevated, and they don't have a compensation with a board under. Well, there's something going on with the ankle. Typically, it's some muscle imbalance, something that's tight. If they don't have any improvement, there's no, the compensation does not improve, then it's probably a lumbopelvic hip complex. So you put the board there, they still fall into valgus even with the feet elevated. You've kind of eliminated the lower extremity, and now you've got to be like, okay, this isn't coming from the lower extremity, this is coming from the lumbopelvic hip complex. So that's huge, right? You've actually taken a compensation you don't know where it's coming from, and then by simply elevating the heels, that compensation, is coming from, if your compensation improves, then it's lower leg. If your compensation does not improve, it's your lumbopelvic hip complex. So I think that's, really quick way to ensure that you're looking at the right structure pretty quickly. I mean, that's just, one thing that we're doing to make sure that we're keying in on where is the muscle dysfunction happening. You can also put the hands on the hips if they're having trouble keeping their arms up, and you're looking at possibly the lower extremity, and you really don't care that much about the upper extremity. Put their hands on their hips and have them do the overhead squat with their hands on the hips, and see what happens there. Just because if they're so focused and their balance isn't good, you might see some potential problems with keeping their hands straight up in the air. So here's a video of our model who we've been kind of tracking through this entire video. This is another video. We're looking at her movement, and I think as you watch it, as you click on, you can see her moving. Everything just seems to be in rhythm, right? Everything just seems to be working really good. She's got good length tension relationship. She has good force coupling. Everything is moving. She just looks so much more comfortable. She is a power lifter, so it's pretty common that they have tight gastrocnemius, and her hip flexor and gastrocnemius are both tight, and that's why you're seeing some of that dysfunction. Overall, though, she's a pretty good mover. So that's it for the double leg overhead squat assessment. Now we're going to go into the single leg squat. And this assessment is a little bit more dynamic, and you're looking at lower body dynamic flexibility, and you're looking at neuromuscular control, as well as balance from a unilateral stance position. So balance is key. Some of your older patients, or older clients, they might not even be able to do this part of the test. So make sure that they have good enough balance that they can do a single leg squat. Now, this provides a greater challenge for the lumbopelvic hip complex because obviously the base of support of the body has been reduced by 50%. So instead of being able to have 2 feet on the ground, you have 1 foot on the ground, so the lumbopelvic hip complex really has to fire up. And this forces the core and the proprioceptive mechanics to work a little bit harder. And you also have looking at everyday movements. We don't spend we do spend a lot of time on 2 feet because walking pattern is typically 2 feet, but there is a transition from 2 to 1, 2 to 1, 2 to 1. So it's more functional. And then if you have someone who's a runner, someone who jumps and lands, we do spend a lot more time moving and jumping and landing on 1 foot versus 2. So it does assess a little bit more functionally in movement for everyday activities. So the single leg squat is a huge aspect of the entire overhead squat assessment. Your start position's a little bit different. You're starting, you do start with your shoulder, feet shoulder width apart. Then you put your hands on your hips, and then you shift to the one leg, right? So you're going to shift to the one leg. And you're going to do 3 squats with the hands on the hip to a comfortable depth. You don't have to go as far as you did with the overhead squat assessment double leg, but you are going to squat until the individual feels comfortable. With the single leg squat assessment, you're doing just the one view. You're just going to do it from anterior. You can look at it from different views, but I can get everything I need from the anterior. You're going to be looking at the foot, knee, lumbopelvic hip complex, and also the upper body. You're going to see if the foot flattens. You're going to see if you have knee movement that's going into valgus or varus. You're going to look for hip hike or hip drop. And typically we're looking at the non-weight bearing side. And for the upper body, you're looking at inward trunk rotation or outward trunk rotation, again with the stance leg being that what we're referencing the inward and outward trunk rotation to. So here's another video of our model, right leg.
Just like 5 minutes, 50 RPMs, just a quick
All right, so you're seeing something a little bit different. Now remember, we've been following this model throughout the whole presentation. We never once saw any type of valgus. But what we're seeing in this video is she's going into valgus quite a bit, and she's also having trouble with balance, and she's also having a hip drop. So we didn't see any of that when she was doing the double leg squat, and just by simply doing a single leg squat, we're certainly seeing quite a bit of compensation and quite a bit of atypical movement patterns that are kind of dangerous and look to be something that we really want to look further into. Here's her left leg. This too is a video. So when she does the left leg, it looks a little better at first, but then you see that there's a little bit of balance issue again, rotation issue. I would say it looks better, but I also know she's not going as deep. So if she went a little bit deeper, I'm wondering if she would have had compensation there as well. So another thing I'll do is single leg step off. I will add this to the overhead squat assessment in the single leg squat as a dynamic evaluation of biomechanics and function. A lot of knee injuries will happen in the valgus position. So I like to take a look at, what's going to happen when they're just landing as opposed to being a little bit more static. So here's a video with a right leg step off. This is just a 10-inch box. She's not jumping off, she's just going to step off. So here's a video, and I just look at see what's going to happen when she lands. She lands and she looks pretty good. Take another look at it if you hit video clip. But she is definitely leaning forward, and something I would want to look at a little bit closer. But all in all, it doesn't look too bad. Again, we're looking at just the left leg step off. So we'll go ahead and hit play.
Good.
Ooh, that looked a little stiff, didn't it? So that stiffness on landing, I never like to see that. That's trainable though. That's sticking that landing like that. That's something that you can train. You want to see some deceleration there. So didn't get exactly what I needed to get on that video. Another thing I like to do is what I call a functional movement scale. I like to evaluate the athlete's movement of agility, power, speed, function, and strength. Right now there's no validity or reliability set of data on this, but it's something I like to add, and it does give me some additional information. If we get enough data together, hopefully we can get something, some normative data. So the two tests I like to do are the standing long jump and the vertical jump. I'm looking at these not from a performance output, but from a movement output. I have videos of some good movers and some not so good movers. You'll be able to tell which one's which, and I will move along from here. So this is my standing long jump. This is an athlete who had bilateral patellofemoral pain. She is definitely her movement pattern is pretty bad. You'll see from preparatory to landing that she has significant movement issues. And let's just play it real quick so you can see what I'm talking about. So her preparatory movement and her landing.
One more time.
So she's not happy about having to do any of this. You can almost hear her knees click.
There you go.
So they click on preparatory, which means they're slapping together into valgus, and then she also goes into valgus when she lands, and you can see that when she did land, she almost fell forward and didn't have a lot of balance. And the reason she fell forward is because she had an excessive forward lean. She was real stiff on her landing, and basically had to take her whole squat, and she had to relearn how to squat. We had to really build the external rotators and her glutes. We tried to inhibit her adductors as much as possible, and did a lot of stretching of her adductors and strengthening of her abductors. So her whole movement quality was poor, and she was chronically injured with patellofemoral pathology, and you can tell just by the movement pattern that she didn't have the strength to sustain movement, and she didn't have quality of movement. And then you start to compare that standing long jump to someone who moves a little bit better. So this is our model that performed the standing long jump. So if you watch her preparatory, landing, you can tell her strength and conditioning background paid off right there. So nice preparatory movement, nice landing, nice deceleration, good positions of her lower leg, good force coupling. And here we have a vertical jump, straight up. This is, again, our bilateral patellofemoral pathology. She's going to do a vertical jump for us, so if you go ahead and click on the video.
Just vertical
again,
jump size, you can go.
Again, very excited to do this for me. You can see how her legs fall in again to valgus. Just really a concerning movement pattern for a college athlete, or for anyone. And here's my more trained mover. Again, hit the video. You can see the preparatory movement. Goes out into external rotation a little bit. That's has part of her strength and conditioning background. So if you play it one more time.
Yep.
She falls back a little bit on her heels, but she does have a good control of her knees. All right, so what are some of the most common findings that I have come across utilizing this information? Definitely seen a lot of excessive forward lean. Weak intrinsic core is one of the main factors there. Tight hip flexors, weak gluteal areas. So excessive forward lean, especially in my females. Again, in my female population, I see a lot of knee valgus, especially with a single leg stance. We can attest to that, to the weak gluteal region, overactive adductor area, and sometimes poor balance. And balance is really the key to good movement patterns. I see a lot of foot pronation. This could be the anterior posterior tibialis imbalance. Remember, the posterior tib is responsible for decelerating the foot as it goes into pronation when you go from heel strike to toe off. So that posterior tib has to really be trained to help decelerate pronation. So the posterior tib is critical, and if you have an imbalance between the anterior and posterior tibs, you can see some of these imbalances. If the heel raises during a squat, you have probably an overactive gastroc soleus or tightness. Ankle range of motion isn't where it needs to be. So making sure you have good range of motion and a strong anterior tibialis to compensate for the soleus gastroc region. But that's really a range of motion thing. If you have a correction with the heel elevation, again, correction with heel elevation, it means that you've eliminated the problem from being at the foot or even the knee. So it's probably a lumbopelvic hip complex, i.e. hip or low back type of pathology. So keep that in mind. And with my landing stuff for the lateral, or sorry, for the long jump and the standing long jump and the vertical jump, if they're erect, then they have a poor landing technique that can be taught, which you saw in a couple of those videos. So correction for that excessive forward lean. When we see that in the lateral view, take these overactive, the grouping on the left-hand side, take those overactive and let's inhibit those, let's stretch those. Take those underactive, let's fire them up, let's get some isolated muscle function and training of those muscles, and see if we can correct some of the biomechanics as well. Taking a little bit further with the overhead squat, excessive forward lean. Some of the things I see with a single leg squat. I see that the foot flattens and the knee moves into adduction and internal rotation. We're going to get that goniometer out. We're probably going to see decreased dorsiflexion and a decreased hip extension. And with the manual muscle testing, we're going to probably see that one of the following muscles are weak, such as the anterior tibialis, the gluteus maximus, and the erector spinae. So when you look at the solutions table, take it a step further. Don't just use the solutions table. Let's use all of our skills. Let's make sure that we are using the skills and knowledge that we have as athletic trainers, and really, do a thorough assessment after you do the overhead squat assessment to get a good picture of what's going on with this individual. So this is a sample corrective exercise program for that excessive forward lean. As you see from the beginning, when I looked at, how do you put this all together, the different phases, we're going to inhibit, lengthen, activate, and integrate. These are different ways that you can do that through modalities, muscles, and variables. So I would invite you to take an opportunity to look at this further as time is starting to run out. So I hope that you gained an understanding that movement assessments are the cornerstone of an integrated assessment process, but not the only part of the assessment process. It's just another tool in your toolbox and not the end-all be-all. We have to make sure that we are using all of our skills to do that assessment. They can be used to observe the length-tension relationship and the force coupling relationship and joint motion of the entire kinematic chain, which is awesome. I always look at the body from the entire kinematic chain, as you probably do as well. And this is only part of the assessment, as I talked about quite a bit. But we want to see how our patients move and how they should be moving, and really focus on optimal health and well-being. So these are some of my references, and I just want to take this opportunity to thank you again. I hope you found this helpful, and I hope you'll use it, because it's been a cornerstone for my evaluation for years, and I hope you got something out of it. I also hope everything's going okay over in your neck of the woods, and that you're treating individuals with spirit, mind, and body in the forefront. So take care, and thank you again.